everyone. We want to thank you for tuning into this pre-recorded webinar, chatting about CHIPS. My name is Gina Rodriguez, and I serve as the project manager for the Community Health Training Institute. It's a project that is housed in Health Resources in Action and funded by the Massachusetts Department of Public Health. We offer trainings and webinars all throughout the year, and thanks to the generous funding from DPH, all of the trainings that we offer are absolutely free. If you want more information about our project and all of our offerings, please visit us on our website at hriainstitute.org. And now I'm going to hand it off to our presenters to introduce themselves and get us started.
Hello, and thank you for joining us for today's webinar where we will be chatting about CHIPS, which stands for Community Health Improvement Planning Processes. CHIPS are one of 3 funds part of Massachusetts Community Health and Healthy Aging Funds, overseen by the Department of Public Health. My name is Jamia Tappan, and I work with Health Resources in Action as a CHIP Program Officer for the Massachusetts Community Health Fund. I'm joined by Jenica Allen, the Community Health Planning and Engagement Health Specialist at the Department of Public Health. Together, Jenica and I will lead today's session to share more details regarding community health initiatives and the community health improvement planning process. Today we have 2 key objectives. First, we want to share the basic community health initiative components of the DON and clarify how DPH uses the DON application process to align both hospital and other community health improvement planning processes when working with health systems. Second, we will discuss the main components of a successful CHIP, including how to engage other partners in your CHIP and how to formulate strong proposals on a future CHIP funding opportunity. We wanted to start this discussion by sharing one definition of health equity. That is, everyone has a fair and just opportunity to be as healthy as possible. To achieve this, we must remove obstacles to health, such as poverty, discrimination, and deep power imbalances, and their consequences, including lack of access to good jobs with fair pay, quality education and housing, safe environments, and healthcare. We'd also like to share this quote by Martin Luther King Jr. Of all the forms of inequality, injustice in health is the most shocking and most inhuman because it often results in physical death. Equity is core to the vision of both HRIA and DPH and is foundational to the Massachusetts Community Health Fund. As the vision of the fund is to transform Mass communities so all residents have an equitable opportunity to have the highest quality of life possible, we believe in the importance and acknowledgement of this visual, which we've informally referred to as the health tree. At the top of the screen, you'll see the text health outcomes, which are the leaves of the tree, which are influenced by health behaviors, the branches of the tree, and are shaped by the social determinants of health, the trunk of the tree, and the health inequities are created and perpetuated by root causes. Here you can see some of the root causes, such as racism, sexism, and institutional barriers that may influence the distribution of social determinants of health, such as education and housing. To fully understand the context in which we live, we need to dig deeper and wrestle with these complicated and unwieldy roots that feed into the tree. These connections are critical to identify and to begin advancing equity in health. I will now turn the discussion over to my colleague, Jenica.
Thank you, Jamia. I'll give a little bit of background now on the determination of need. Massachusetts Determination of Need, or DON regulation, is one tool we have to require and encourage health systems to move upstream. The purpose and objective of the DON program is to encourage competition with a public health focus, to promote population health, to support the development of innovative health delivery methods and population health strategies within the healthcare delivery system, and to ensure that resources will be made reasonably and equitably available to every person within the Commonwealth at the lowest reasonable aggregate cost. Recognizing that DON represents a significant state executive branch tool, we realigned and redesigned the regulation in 2017 to advance the state's public health and healthcare reform goals. This included a laser focus on how health systems understand and address social determinants. A major way this happens is through a tool unique to the Massachusetts DON regulation, which requires the health system to invest in a community health initiative, or CHI, as part of the approved DON project. As you can see on the slide, the way this works is that a health system identifies a need to expand or improve healthcare facilities or services. This is the DON project. That project has a total cost, the maximum capital expenditure, or MCE. 5% of that MCE becomes new money that needs to be invested in a community. This can result in a relatively small amount of money, such as 5% of a new PET or CT service, or very large amounts of money, as with 5% of a $1 billion capital building project. Massachusetts has had this contribution as part of the Determination of Need program since the mid-1990s. And with the update to the regulation in 2017, we made several important changes. The 5% contribution was fully codified in the updated regulation. It had been a customary contribution, but was not fully supported by regulatory authority until 2017. Additionally, we established in the regulation that the DON applicant is required to address state-defined health priorities. By including this in the regulation, we were able to set new standards through sub-regulatory guidance, which ensures that CHI dollars are planned through an inclusive process and that strategies address the social determinants of health, and that the CHI planning process influences community health planning activities undertaken by hospitals to meet IRS and Massachusetts Attorney General requirements for community benefit. I will now talk a little bit more about how we do this. When we looked at the current state of play in community health planning processes, we found in our review that the process lacked critical synergy between state-required CHI and both state and federally required community benefits. There are too many community health needs assessments conducted for similar purposes, burdening stakeholders and creating redundancy. This leads to both unaligned health priorities and uncoordinated investments in community health interventions. By requiring DON applicants to comply with DPH-issued minimum standards for community health needs assessments and community health improvement plans as it relates to meaningful and measurable community engagement, DPH, working with the state's Attorney General, has successfully aligned these state and federal processes while significantly raising the bar and minimizing administrative duplication. In doing this, we view CHI from a systems transformation frame. This approach allows providers to leverage existing community health needs assessments, minimize duplication of stakeholder engagement efforts, standardize definitions, approaches, and evaluation of community engagement, leverage potential alignment of priority health needs, select similar or complementary interventions across providers and systems of care, and leverage joint resources for larger community impact. These DPH standards also require that CHI investments in community benefits be separate dollars, but encourage that all of these dollars be focused on the social determinants of health. With this new purposeful alignment and approach, we have a system where CHI and Affordable Care Act or Attorney General requirements are coordinated. This has many benefits. First, with DPH now having a role in how the community is engaged and how data and information are used in needs assessment and CHIP processes, opportunity exists for aligning community benefit determinations with the types of strategies being funded through CHIs. Next, through the standards developed by DPH, CHIs will have to meet community engagement standards, and CHI investments will need to address the DON health priorities with evidence-informed strategies that directly impact the social determinants of health, which again, over time, may also lead to a social determinants of health approach to community benefit determinations. Additionally, while applying state standards, this approach allows healthcare systems and their partners to choose local approaches to address the social determinants of health. Finally, this supports the rationale and operation of a new CHI statewide initiative that sustains coordinated local CHIP efforts, system-wide evaluation, and support to historically under-resourced areas of the Commonwealth. And continuing with community engagement, we believe community engagement is a critical ingredient in eliminating health inequities. Simply put, it is not possible to understand and address root causes without authentically engaging with the individuals who are directly experiencing the systems and environments that create inequitable outcomes. We leaned on national best practices from community-based participatory research and on community health improvement resources from places such as the CDC to establish minimum standards for engagement based on the 5 steps of a community health improvement planning process. These standards require hospitals to utilize the widely known public participation spectrum to set goals for engagement. The standards further provide guidance on topics such as sector representation on advisory boards. We are trying to build the case for agency in order to achieve our goals of public health. Community engagement is the foundation of community health improvement planning and the foundation of DO1-CHI. To support this principle, DPH uses the spectrum of public participation as a tool and as a resource. So when we are able to move along the spectrum of engagement, there are tremendous benefits. Even anecdotally, it is really awe-inspiring to see people believe they have a say, not just overall, but also in their own situation. It might seem sort of counter to a systems approach where we know health inequities come from systems of oppression, but I think it's more about being able to better problem solve in the space of really understanding how oppressive systems function. If formal knowledge is made accessible, if people in a more fully informed manner are given choices, real options that can be pivotal in people's lives, their outcomes in basic concepts like social capital, social cohesion, feelings of hopelessness, safety, security are likely to improve. This is where we see all the different types of power play into community engagement. Generally speaking, people with power like to hold on to power however possible. So changing the current power system is challenging. By using tools that can give us insight into and shine a light on the different dynamics of partnerships, power imbalances, we can start to promote agency and decisions that affect people's everyday lives. DPH uses the spectrum of public participation to understand the current state of health system community health improvement planning and uses it to push them further along the spectrum. DPH has defined the health priorities for the DON program as 6 social determinant of health domains, listed here on the slide. At the same time, we established a series of health outcomes and problems that we know to be pressing and consistently impacting population health and health inequity, a central concept in this. Accordingly, hospitals are required to focus their CHI resources on strategies that address 1 or more of the 6 DON social determinants of health priorities. Those are built-in physical environment, sociocultural environment, housing, violence and trauma, employment, and education, to improve population health outcomes and issues, including but not limited to chronic disease, housing stability and homelessness, mental health and wellness, and substance use disorders. In this way, we are ensuring that hospitals invest resources in primary prevention activities that work to change community-level conditions. Importantly, the Department of Public Health has also encouraged hospitals to be explicit concerning the role of structural racism in creating inequitable community conditions. When hospitals provide to DPH detail on the strategies they intend to implement, they are required to answer questions such as, what is the inequity of interest? Where or what is the injustice, that is, the source of the inequity the strategy is trying to solve? Are racial outcomes different? What other differential outcomes of interest are notable by other population groups? Does this proposed strategy address racial or other inequities by helping to dismantle structural racism or other structural causes of inequity, either through policies or systems-related change? Is there opportunity to think how it could? What might be the unintended positive or negative outcomes of this proposal, for people of color or other population groups that the strategy is focusing on? What are you doing to ensure negative unintended outcomes are addressed or mitigated? In choosing strategies, DON applicants will use this basic process: review the DON health priority descriptions, identify issues in priority populations from local community health needs assessments and CHIPs that relate to the 6 social determinants of health, and select appropriate strategies using the 4 strategy selection criteria. Those criteria are: demonstrated impact on 1 or more of the 6 social determinants of health, demonstration that the strategy is evidence-informed and shown to impact health outcomes, demonstration that the strategy is a community clinical linkage or a community-wide policy systems or environmental change strategy, and demonstration that the strategy will impact populations that need it the most and is feasible to implement. Applicants may also be required to submit a health priority strategy selection form that DPH approves, outlining how chosen strategies meet these criteria. As with all aspects of the CHI program, the long-term goal is that by requiring a social determinants of health focus for CHI, and by requiring leveraging of existing community health improvement planning processes, we will be encouraging a social determinants of health focus for all community health planning and improvement processes that health systems are involved in. Importantly, throughout each of these stages, the applicant is encouraged to continue asking racial justice framing questions. The 5 questions are: who benefits? Who is harmed? Who influences? Who decides? And what might be any unintended consequences? These questions are critical check-ins at all decision-making points. Community health initiatives happen regularly in areas of the state where hospitals are routinely going through the DON program. This slide, which shows data from 2002 through 2013, was used in the original planning and discussions that led to the creation of a major change in the DON CHI program, which resulted in the creation of a statewide investing system designed to carry the principles of the CHI program across the state and to invest in areas of high need and where there have been fewer CHI resources available historically. This slide shows the basics of what the statewide fund is supporting. The goals, which I started to talk about a few slides ago, are CHI system-wide evaluation, local grants supporting DON health priority strategies, and resource support for regional and collaborative community health improvement planning. The details around funding and operations are listed here. For projects that result in a CHI total of $500,000 or more, 75% of the CHI total will be dedicated to local approaches, and 25% will be contributed to the CHI statewide initiative. For projects that result in a CHI total of less than $500,000, the contribution to the statewide fund will be 10%. Finally, one of our goals with the statewide fund is to support CHIPs that are community-led and in which health systems are participants, removing the health system as the primary funder. The hope is that over time, these community-based CHIPs will be the foundation for community health improvement planning that health systems use to make their community benefit in CHI-related decisions. And with that, I will turn it back over to Jamia. Thank you.
Thanks, Jenica. So now we're going to focus specifically on the Community Health and Healthy Aging Funds. 2 advisory committees were established through a competitive process to guide the vision of both of these funds. For the purpose of this presentation, we are focusing our attention on the Community Health Fund Advisory Committee. They developed the vision to guide the Community Health Fund, which states all Massachusetts residents have an equitable opportunity to achieve the highest possible quality of life. This vision aligns with DPH and HRA to eliminate health inequities through addressing the social determinants of health. To reiterate our health equity framework, structural and institutional racism and other forms of oppression need to be understood and disrupted to eliminate inequities in population health outcomes and social determinants of health. Policy systems and social physical environments are historically based in structural and institutional racism and other forms of oppression. Therefore, it's important that we account for significant variations in health outcomes through the social determinants of health. The Community Health Fund has 2 areas. The first is PSE, or Policy, System, and Environmental Changes. Policy refers to regulation or laws. Systems refers to organizational or institutional changes, and environment to physical or social. These changes usually focus on policy change, on regulation changes and strategies across the PSE fund, and may focus on a geographic or population-based community at the local, regional, or statewide level. The CHIP, or Community Health Improvement Planning Funds, support the development and or implementation of local and or regional community health improvement planning processes. To provide additional context to what we heard Jenica discuss earlier, we can leverage shifts in healthcare, new hospital requirements, and DON applications to improve community health initiatives across the state. This alignment across the health systems provides additional support and funding to mass community health funds, and specifically the community health improvement planning process. This is a graphic adapted by HRA from the Association for Community Health Improvement. The colored wheel shows the 9 steps of community health improvement. Think of this as a 9-step pathway for conducting a community health assessment and developing implementation strategies. At the center of the wheel, or circle, you see the community engagement is core to each step in the process. I'll walk us through each wheel. First, we want to reflect and strategize. This is a chance to reflect and get feedback on previous assessments, obtain leadership support, build your team, and identify resources. Second, we want to identify and engage stakeholders. Here you can develop an engagement approach and identify stakeholders to participate in the process. Next, we want to define the community. And by community, we mean both the geographic community and population groups. It's also important to this step to identify other organizations conducting health assessments. As you collect and analyze data, there are many types of data to include in your assessment. Both quantitative or numerical population data and qualitative or descriptive data based on opinions and perceptions should be collected and analyzed. When developing a data strategy and deciding what data to include, it's important to detect health inequities and to reach populations facing those inequities. It's crucial to engage the community throughout this step. Through community surveys, key stakeholder interviews, focus groups, or other community meetings. Next, you want to prioritize community health issues. Before prioritizing the issues, you should identify the criteria for prioritization. Consider need among vulnerable populations, ability to have a measurable impact, availability of resources, among other criteria. At the end of this step, you should be able to describe which needs were not prioritized and why. As you document and communicate results, you want to make sure this assessment period, after the assessment period is over, you publish the process and the results. Ensure that material is presented in an accessible way and publicize those results. The next step is to plan implementation strategies. Throughout this planning step, engaging strategic partnerships is key to align strategies for the greatest impact. Set goals and objectives and make sure you tailor your strategies so that they are appropriate to your community. Next, you move into the implementation of those strategies. In this step, you want to assemble an implementation team and develop an action plan to improve your strategies. Continue to engage the community throughout the implementation process. And lastly, you want to be sure to evaluate your progress. You'll need to first establish a baseline, focus the evaluation design, gather evidence, measure progress, and justify your conclusions. It's important to use evaluation results to improve your strategies and to communicate your findings. Throughout the assessment and engagement process, we really want to move towards collective impact, which includes a shared vision, goals, and metrics across multiple organizations and sectors to achieve health equity. As you build trust and deepen your partnerships, it's important that you mutually reinforce your shared objectives and priorities and make sure those activities are clear and you're communicating with one another across the partnership in order to achieve the collective impact. As you consider your community engagement process, it's important to think about cross-sector engagement in key sectors such as service providers, faith-based organizations, coalitions, government, or business industry, and identify who those key stakeholders are. This tool is just one example of how you may engage different stakeholders throughout the planning process. Along with the steps on the previous slides, we wanted to highlight what we think encompasses the key components of a successful CHIP. We want to ensure your process is rooted in health equity and works to build deep partnerships with multi-sector stakeholders. We want to make sure you identify clear and measurable objectives that lead to overarching priorities for your geographic area. Finally, you want to make sure your plan has buy-in from all your partners and that the larger community is on board in order to reach collective impact. And if you're considering applying for CHIP funds in the future, here's what we feel makes for a strong proposal. You want to make sure that your CHIP process aligns with the 9 steps that we outline, and that there's data supporting the need for your CHIP, and that you base those things around health equity. Your approach should not only be rooted in health equity, but should be framed around the social determinants of health and the community engagement processes that we've outlined earlier in this discussion. And for resources, you want to ensure that there's alignment across your organizational partners so that there's buy-in in the community to support sustainability. If you have any additional questions, please feel free to reach out to Jenica or myself. Our emails are there, and it will also be in the information box.
Thank you for tuning in to this recording. If you have questions, you want more information, or you want to learn more about the Community Health Training Institute, please feel free to visit the links and the resources listed in the comment box below. We'll see you next time.